All right, awesome. So now we're being recorded, and I just wanted to do a quick introduction to our speakers for today. First is Mels, who is the nurse educator for the Perinatal Network and housed somewhere on campus. And then also April Caruso, who is the clinical nurse specialist for the Family Birth Center and OB services. And so they're going to take us through OB hemorrhage. And we have both the 6 o'clock session and then also a 7:30 session for those that prefer the later evening session. And then so I'll just turn it over to Autumn and April, and then they can walk us through any requirements that they have or any other comments.
Yeah, guys, welcome. Thanks for joining us tonight. Like Gabe said, I'm Autumn Mels, the OB Outreach Educator, and then I have April sitting right next to me. So we'll just go ahead and get started to respect your time. Just a couple things before we start. I do just want to state that neither April or I can speak on behalf of both of us. Neither of us have any financial relationships. We don't represent anything specific from any pharmaceutical companies. We will be talking about some specific drugs and medication treatment algorithms, but we are not being paid by any of them to talk about those things. Criteria for successful completion of this obstetrical hemorrhage course does include attending the entire hour of the program, completing the post-test and scoring above 80%, and then submission of a post-class evaluation tool, which we'll talk about that, how you'll do that at the end of the presentation. You are getting 1.25 CEs for this course. This component of it, the live version, is only an hour, but then you get the additional 0.25 for the time taking the post-test and completing the evaluation for that. So some different objectives of this obstetrical hemorrhage course is we hope by the end of this hour, you'll be able to understand the 4 R's model, which include readiness, recognition, response, and reporting in relation to an OB hemorrhage, identifying patients who might be at risk for a hemorrhage, recognizing when a hemorrhage is occurring, comprehending how to obtain quantitative blood loss, identify appropriate nursing interventions to manage a hemorrhage, then understand proper hemorrhage medication use, and appreciate the importance of teamwork in a hemorrhage situation. So we'll just dive in, and one of the first things I want to just talk about and address that you guys may or may not know being ER providers is that unfortunately we're seeing a rise in morbidity and mortality. And actually obstetrical hemorrhages is one of the top reasons of why we're seeing an increase in morbidity and mortality in our moms. And you can see on this chart too, it shows postpartum hemorrhage with blood transfusion is on the rise, as well as postpartum hemorrhage with obstetric procedures to control that hemorrhage are both on the rise. So we're seeing a rapid increase in that from happening. So certain individual and team skills require regular practice that cannot ethically occur in the routine care. So it can be very, very hard for us to practice some of these skills. Hemorrhage skills may be coming in the future to the ED, but it's something that's hard to ethically do right in our normal practice on a day-to-day basis. So it's really, really important that we can at least talk through how we would manage these situations to help improve our patient outcomes. So the very first thing I want to address, just one quick slide here, just to talk about some really basic changes that we might see in a woman who's pregnant. So some of the main things from an ER standpoint that I think is important for you guys to know is that there's a large increase in plasma volume. So there's additionally about 1,100 to 1,600 mLs of additional blood when a woman becomes pregnant. And that's, essentially to supply the metabolic demands of the uterus, placenta, to help with nutritional transportation to that growing fetus, etc. So we do see a large increase in blood volume in our pregnant moms. Increased RBC mass by approximately about 20 to 30% higher than a non-pregnancy state as well. There is something that our pregnant moms go through too. It's physiologic anemia. So sometimes in pregnancy, we can actually see a decrease in a woman's iron. That's due to the increased oxygen demand of the fetus. But then also, we just talked about an increase in the woman's blood volume as well. So it almost like hemodilutes the amount of hemoglobin that we can see in our women's blood. So sometimes we're not too surprised if we see a slight decrease, but we still need to pay attention to that. And then we also have an increased cardiac output in our moms. Obviously, the mom's heart is working a little bit harder, right, to help push that extra blood volume around and to reach our uterus and our baby. Increased WBCs as well. It can go up as high, increased WBCs can go up to as high as about 20,000 per se in about a pregnant woman. That's essentially right. Think about the pregnant women as they're immunocompromised. Their body is fighting harder to help prevent any infection, bacteria, to protect both themselves and the baby. So we can see that, higher amount. Sorry, guys. And then a normal pregnancy is a prothrombotic state. So essentially what happens is that there's an increase in coagulation factors within a pregnant woman. And the reason for that is that the body automatically, when a woman becomes pregnant, these thrombotic factors start to increase because the body's preparing for that delivery. So the body knows that the woman's going to deliver, she's going to bleed. It wants to prepare to help reduce the amount of bleeding that the woman has. So we can see an increase in our fibrin levels. We can see an increased platelet reactivity. And like I said, that's for when the woman's going to deliver. So we're not surprised if we see this increase. So those are just some basic changes that you might see in a woman who's pregnant, or maybe if they're newly postpartum, some of those things might still be occurring in someone who's newly postpartum. Now one of the objectives I talked about is knowing the 4 R's, which include readiness, recognition, response, and reporting systems. And this essentially comes from California is actually one of the first states in the United States that developed a really good hemorrhage quality initiative. And these are 4 components that really have latched on to managing obstetrical hemorrhages. So these are the 4 things that we're going to talk about to kind of help guide our discussion and our plan of managing an obstetrical hemorrhage. So the very first thing I want to talk about is just being ready and being prepared. So any unit that might care for a pregnant woman or postpartum woman as well needs to be prepared. So these are some components of this readiness, and that's having a hemorrhage cart with procedural instructions. So I am not sure exactly what a hemorrhage, if you guys have a hemorrhage cart or a hemorrhage kit in the ED, but this is an example of one that we actually have at the university on our labor and delivery unit. It contains a lot of different equipment that you might need, just pretty much anything that you would need. You can pull this whole cart into the room to help care for that hemorrhaging patient. It actually includes, up here, we include our uterotonics, so different medications that we would use, what the dosage would be, how often the nurses could give it. So it has all that on there. The meds I'll show you, they'll actually be in our Pyxis. But then also it includes something that is important is measuring our blood loss and actually weighing it. And we actually have weighed out all of the different things that potentially could be underneath our pregnant or postpartum patient that we might need to weigh to figure out what her exact quantitative blood loss is. So all these things on our hemorrhage cart. So it makes it easy when a patient is experiencing that, we can just pull that whole cart into the room and we have all of our equipment there except for our medications. Then having rapid access to hemorrhage medications, a kit or something equivalent to it. This would be something that I would encourage you all to look at in the ED to see what you guys have access to and is readily available. And I think about that doing like a mental rehearsal. So kind of thinking to yourself, like, let's say if I had a patient to come in who might be postpartum and is bleeding, I need these medications, where would I find them or how could I access them? That way, if you did ever have that happen, you would know how or where to find that, both at your hemorrhage cart per se and your medications. Then establishing a response team. So making sure we're having multiple partnerships or unit education, which is obviously what we're doing right now. Maybe some drills will be coming to the ED, would be nice. And then doing some debriefings. So obviously you guys have a close relationship with labor and delivery. You'll have rapid access to, an obstetrician who can hopefully come help you guys as soon as you have a pregnant or postpartum patient, but just making sure that we're working closely, communicating with each other, and how we can help one another with these situations. And then establishing a massive transfusion protocol, or an ONAG, or on-cross match transfusion protocol, which is in place at the University of Chicago as well. And I'm hoping that you guys are aware of how to initiate that. I'm sure you guys do that a lot in the ED, of how to use that as well in these circumstances. So this next slide is an example. So this next slide is an example of our hemorrhage kit. So this is what we actually have on our unit. So we can actually go into our Pyxis and we can actually click on remove kits. And we have a whole kit readily available that then goes, it's only in our antepartum Pyxis, I'm sorry. So we can actually click on remove kits. It pulls up a whole hemorrhage kit and it talks about with the use of Pitocin, which is the first line of medication we use to manage a hemorrhage. And then if we're still having complication, or we want to make sure that we're notifying everyone on the unit that we need some help. So if we're having an emergency and we need help, we can notify our whole unit. And then we would say for a hemorrhage. So I'm not sure in the ED exactly what you guys have of notifying maybe someone in the ED that you're having a hemorrhage, but this is, for example, of how we do it in OB. We have these wall panels in every single room. So the next part, we have readiness, so being prepared. So having a patient, right, we know we want to be aware when they're coming in. The next thing is going to be recognition, and this means paying attention to every patient. I think the biggest thing, especially from an ER standpoint, is going to be really important for you guys to ask that question to anyone who might be of childbearing age, asking them if they are pregnant, if there's any chance they could be pregnant, or if they have been pregnant within the last 12 weeks. And I say that because women can actually hemorrhage up to 12 weeks postpartum. So they can have an early postpartum hemorrhage, which is like in the hospital, or they can actually go home, and then sometimes we'll see them come back bleeding. So we need to make sure that we're doing a hemorrhage risk assessment, which I'll show you guys on the next slide. And then making sure that we're having a measurement of our cumulative blood loss. So we try not to estimate our blood loss anymore. We found that we are very poor estimators, just specifically looking at the blood on the floor on our patient, trying to determine how much is there. So we really want to try and weigh everything. And then active management of our third stage of labor. So when I talk about a risk assessment, this is essentially what we use for a risk assessment in OB. And a lot of these questions I think are pretty basic, but thinking about asking the patient if they've ever had any uterine surgery, if they're pregnant with one, or if they're postpartum, if they were pregnant with one or multiple babies, how many vaginal births they've had, any bleeding disorders, clotting disorders, essentially is what we want to know. So any uterine abnormalities or any history of hemorrhaging. So related to recognition, these are some of the main risk factors for a woman who is bleeding. So it's really important to know if they've ever had a history of a hemorrhage, any bleeding disorders like we've talked about. Chorioamnionitis is actually an infection in the uterus. So if they had any of that when they're maybe in labor. If the woman is obese, fetal macrosomia is a large baby, and then multifetal gestation is more than one fetuses. So if they had a large baby or multiple fetuses, it can actually over-distend the uterus. And it's hard then for that uterus to sometimes clamp back down to help stop their bleeding. Preeclampsia, if they had a long labor, they had any placental abnormalities, if they've had grand multiparity, which is 5 or more deliveries, or if they've had a previous uterine surgery. So any surgeries done on their uterus can actually put them at risk. So women can bleed antepartum. So this is before even the necessarily the labor and delivery process. And they can bleed maybe because they're in labor, if they had a trauma, maybe they had an accident, etc., or hit their belly and fell. If they have a previa, which essentially means that the placenta is covering the cervix, and then we can see some bleeding. With a previa, we want to be careful if the woman comes in with any vaginal bleeding and they're pregnant, that we don't stick anything in the vagina. We make sure to ask them if they know if their placenta is covering their cervix or not, because we don't want to puncture that. If they have a placental abruption, which means the placenta is actually completely detaching from the uterine wall. They can have a uterine rupture, which is rare, but it does unfortunately happen. This actually means that the uterus actually tears open, especially if they have a history of a C-section. The uterus can actually completely tear open, and the baby can actually go into the abdominal cavity. And then a vasa previa as well, which is when we have essentially placental vessels that aren't protected well with membranes, and those oftentimes will start bleeding when a woman's water bag breaks. It's usually painless, so we just need to make sure that we know some different reasons why a woman could be bleeding and she might still be pregnant. So these antepartum reasons. And then there's also postpartum, which I'm guessing you guys probably see in the ED more of the postpartum reasons, and this could be related to tone. Essentially, if the uterus is boggy or it's not clamping back down after a woman delivers, she can continue to bleed. If there's any trauma, so if the uterus had trauma, the cervix had a tear, if there's a vaginal laceration, all those can continue to bleed. Maybe they had a C-section. Hematomas are another thing to pay attention to. If the woman's complaining of increased vaginal pain, maybe pressure, The hematoma could be on the perineum between the vagina and the rectum, or it can actually be in the vagina itself. So we have to ask for if they're having severe pain, identifying our site of it. Tissue-wise, so when we think about the 4 T's, tissue, the third one of the common reasons can actually be retained placental fragments. And what that means is, unfortunately, sometimes pieces of the placenta can get left inside of the woman after she delivers. When a piece of that placenta is left inside, then the uterus can't clamp back down, and more the reason why the woman could bleed. And then thrombin, these are the coagulopathies that we talked about. If they have any blood clotting blood clotting conditions, any genetics, or maybe obstetrical reasons. Maybe they went into DIC after they delivered. So it completely depends on the cause. So we really need to think like upstream when we're seeing these women who are pregnant or postpartum. And as you guys do in the ED, identify your cause so we can try and treat that rapidly and prevent further blood loss from our patient. When we have a woman who is bleeding, and this is only when she is postpartum. So antepartum, you're gonna have different management, but for a postpartum hemorrhage, a woman who has delivered, if she comes in, or you see her for whatever, if the EBL is greater than 500 mLs for vaginal delivery, we usually consider it a hemorrhage. And then greater than 1,000 mLs for a section. Or if we see these vital signs, so the heart rate greater than 110, BP less than 85/45, low O2 stat less than 95, and they're still bleeding. As I had previously said, we want to make sure that we're identifying our cause, assessing that upstream to help prevent further bleeding. But then the very first line of defense, if you're in the room and you notice that the patient you've identified she's recently postpartum, is going to be to perform a fundal massage. And I know that this may be like, I don't know how to do a fundal massage. I totally get it. Essentially what you want to do is you'll put your top hand up on the top of the woman's abdomen, right by her umbilicus, right by the belly button. And if you actually go and just kind of cup your hand and make it almost like a C and you push down, you should feel like a very firm softball. You might have to go a little bit further down in the umbilicus. It usually goes down about 1 centimeter per day per postpartum. So you know, say she's 3 days postpartum, you might want to go down 3 finger breaths and try and feel for her uterus. And then this lower hand, you'll usually want to go by the pelvic bone, the symphysis pubis, and try and support the uterus to try and hold it in place, to try and give it a good massage, to try and get it to firm up. Now, if you feel the woman's belly and you don't feel anything, it feels very soft and boggy and mushy, you want to keep doing your fundal massage. That's the very first thing that you can do if the woman is bleeding from uterine atony. And then try and keep doing that until you feel it firm up, and then until you can get some help to increase the tone of her uterus. So performed only when postpartum and typically located, like I said, closely to the umbilicus, and then go down 1 centimeter per day postpartum. This is what I had talked about before with the retained placental fragments. And you can see here how the uterus can contract down nicely, can firm up. But unfortunately, when there's something left inside of the uterus, it can't actually clamp back down. This can lead to further bleeding. It's kind of lazy per se.
You can't push too hard is the only thing I want to add. There are blood vessels that run behind the uterus. And with that hand, which is usually your left hand, clamping down on the umbilicus, you can actually really push down. Sometimes you can actually even get a pulse back down in there. You just want to make sure that you're either stopping the bleeding or getting the uterus to firm up nicely. And sometimes that's not possible. So then it's back to trying to stop the bleeding with your hand. And then also, you know, as we'll get to in a little while, the packing of the uterus and a Bakri and things like that we can do from the other side, depending on how well the uterus responds.
The other reason too why you may see some bleeding as well is if the bladder is full. And this is more common in women who are more recently postpartum, I would say. But if you look at the anatomy, the bladder is right in front of your uterus. And if the bladder is full, what it does, unfortunately, as you can see in this photo, is it actually pushes the uterus off to the side, preventing it from clamping back down and preventing further bleeding. So you almost think about like that site where the placenta is attached from the uterine walls, like an open wound per se. We really want that to clamp back down and shrink back down to help prevent that bleeding. And when this happens, this full bladder, it can be really hard for that uterus to clamp back down and prevent further bleeding. So sometimes making sure if you feel that uterus off to either side, left side or right side, it could be that the mom actually needs to void. So, and it might be assisting her to the bathroom or with a catheter. So how much is too much? Just to redefine again, the WHO defines blood loss of greater than 500 mLs as an alert line. So making sure that we're paying close attention, assessing our patients, and then 1,000 mLs as an action line of when we should really be doing something. 1/3 of women with greater than 1,000 mLs actually had no risk factors. So important to look at our risk factors, but then unfortunately sometimes on the opposite end of the spectrum, we see that a lot of our hemorrhaging patients, actually we weren't prepared or we didn't know they would actually have a hemorrhage. ACOG recently came out with a new statement, which ACOG is the American College of Obstetrics and Gynecology. So they're one of our accrediting bodies who guides us in our care. Actually recently said that a cumulative blood loss of greater than 1,000 mLs for either a NSVD, so vaginal delivery, or a C-section with enhanced surveillance and early interventions as needed for between 500 to 1,000 mLs. So like I said, I just wanted to reiterate as well from ACOG, they did recommend too that obviously we see early hemorrhages, which is going to be your patients that are inpatient. We see them when that happens in the hospital within the first 24 hours, but it can happen up to 12 weeks. So please make sure from an ED standpoint, they are asking them about pregnancy. This is an example of a trauma assessment of blood loss. Now I know that from your guys' standpoint, you guys classify or do your different levels of blood loss. In OB, we don't necessarily do that. These are just some different examples of blood loss volume, where we might class them, and then what certain signs and symptoms you might see. And I'll show a more extensive chart that we use in OB that talks about specific what might we find in our patient. But this is just kind of an example of that trauma assessment of blood loss. These are some common objects that we may use when quantifying our blood loss. Again, like I said, remember the ideal method is going to be weighing. And I fully understand that in a hemorrhage situation, you might be chuckling to yourself. You don't necessarily have time to sit there and say, excuse me, while I weigh my chuck. So sometimes what you might have to do is just put those chucks or that stuff that the patient's blood loss is on, just set it aside for the time being until you actually have time to stop and start weighing, or you can get someone to help you do your quantitative blood loss. And remembering that 1 gram of blood loss equals 1 ml. Are going to be the main things for the blood loss. And then using similar objects when you're talking with physicians, or if you need to explain like what size of clot you expelled on the patient or what size you're noticing, just using similar objects that everyone can relate to make it a little bit easier when talking about your findings. So these are just some examples. When we think about quantitative blood loss, we have found that when we overestimate, it is obviously very costly. We're using different things, from both the hospital standpoint and your patient. It's very costly, can be very invasive, the interventions that we use for hemorrhaging, and then we're using unnecessary things that really weren't needed for the patient. And then we know the risks of underestimation, which can be delay, in delivering life-saving interventions, which unfortunately then our patients suffer from. Therefore, the recommendation is for every birth, quantitative blood loss should begin right after birth and continue until bleeding is stable. So approximately 2 to 4 hours postpartum. So for every single patient, we should be seeing this on our labor and delivery unit, that every patient should be having a quantitative blood loss, meaning everything should be measured after delivery. We don't want to see any estimation for that. These are examples of just seeing how much blood loss, where this is 300 mLs, where it might not look like it's actually 300 mLs, and this, we might even think is less as well, but this is already almost a full liter of blood loss. So making sure that, if we do have a patient maybe who comes in to deliver in the ED, that we're using drapes or measuring things, and then also measuring our chucks, or maybe using laps, or maybe using suction containers as well to assess our blood loss. So here again, this is kind of similar to the one that I showed you that we have on the hemorrhage cart on our unit. And you can see, I don't know if you guys have something similar to this on your unit, or if you guys do QBL for anything else, but these are just some examples of dry weights of things that could be on the unit, and then wet, potentially if they're wet with water, fluid, or blood, etc. So then you have to do the math for each thing. Now, please don't use this chart. This is just specifically for teaching and educational purposes, because they can all vary by institution. So I'm not sure what you guys use, But like I said, in our unit, we have standardized, weighed everything out so that nurses have it a whole chart, and they can simply just subtract whatever equipment they used from what their findings are of that QBL. So we need to think about our response for every hemorrhage. So having a unit standard protocol, having a stage-based OB hemorrhage emergency management plan with a checklist. So hopefully you guys have something in place if you did have a patient who was bleeding from, who was either pregnant, which I'm sure you're going to consult OB right away. And considering at the University of Chicago, we should be pretty quick to respond to that. So making sure we know that, and then also assessing our postpartum patients as well and getting OB on consult for them. And then support program for patients, families, and staff as well. It can be kind of traumatic if they come in and they're pregnant or if they're postpartum and bleeding. So just trying to essentially support them. But then also think about staff as well. It can be hard when we take care of a difficult patient or we have a bad outcome, and just trying to support each other and help each other when we see these hemorrhages. So these are some simultaneous steps that we in OB that should happen for a woman who is pregnant or postpartum. So the initial preparations are going to be to get help. The primary RN should always stay with the patient at the bedside. So please don't leave. Hopefully you have some way of notifying a team that you would need rapid access to help in your room, but please don't leave your patient if you know that they're bleeding. We really like to try and get an 16 gauge IV. Rationale for that, as you can see on the bottom right hand corner here, we can get more flow in faster, as you guys know. Even better if you can get two get two IVs in case the patient would need a transfusion or a massive transfusion protocol. You have one for your fluids and one for your blood. Make sure, as you guys know, treat with IV fluids. You guys see people who are bleeding all the time. So I kind of use the analogy of when I would go into ED with patients, and I know that it's scary seeing a pregnant woman because that's not what you guys see all the time, but managing that patient who's bleeding just like any of your other patients who are bleeding, right? So doing your fluid replacement for the pregnant mom is just going to be as important. Putting in your Foley, getting your blood products. Maybe you might just need to do a type and screen, or maybe it's to the point where you might actually want to have some of those blood products on your unit just in case. And then we've already talked about quantifying that blood loss. So here's an example. This is what we use for an obstetrical emergency treatment plan. And this was put out by the California Maternal Quality Collaborative. Again, I'm not going to go through all of this because you guys will be able to have access to this presentation after where you can read it. But essentially it's talking about the different stages that we might talk about in OB, where all of our births might be at stage 0. And then if they have greater than that 500 EBL for a vaginal delivery or 1,000 for a section, they might move up to a stage where we might need to initiate our hemorrhage protocol and management plan. So these are just some physiologic stages, just some things that we might see happen, or like the maternal status, what we might actually see them acting like, or what our findings could be. So we can see as the patient loses more blood, if we start at the stage 1, it's only about at 900 mLs, and then we start progressing, see what starts happening to the pulse, our respirations, and our blood pressure, as you guys are used to the increasing the tachycardia, and then our blood pressure starts to drop. Patient can become anxious, but then it leads to that confusion and lethargy. We see that decrease in urine output, which is why it's important to put that Foley in to help monitor that. Then we can see our fluid replacement. We'll just start with the crystalloids and then gradually increase to potentially using actually blood itself. If we have a patient who's bleeding, we want to make sure that we're getting some of those labs. So if you only have one line on that patient, putting in another, if you can get that 16 gauge IV, grabbing a CBC, your coags would be a really, CBC, if you don't have a type and cross yet, type and screen, type and cross, grabbing those right away can be really helpful to try and determine like where's our patient stable wise, considering maybe from admission to now, or maybe it's your first assessment. And then just doing your fluid plate replacement like you guys would for any patient that's bleeding. If they're bleeding, or it doesn't matter if it's, you know, OB hemorrhage or if it's a gunshot wound, same fluid replacement for them. And then we'll talk about specific to OB some different medications. And these are typically the order per se that you would use medications in, I guess you can say, and we'll just talk about each one specifically. So the very first one that you would use is oxytocin, also referred to as Pitocin. Essentially, the preferred route is going to be to give it IV. You can usually give 10 to 20 units of it per 500 to 1,000 mLs in the IV. Typically, it's made up by pharmacy. I don't know if you guys have it stocked on your unit or not. If you don't have it stocked, you can actually, and you don't have a line on your patient, you can actually give 10 units IM if you don't have IV access yet. So it can be given IV or IM, IV preferred. And you can actually bolus it after delivery. We can actually leave it wide open if the woman's bleeding. And what the Pitocin does is it really helps the uterus contract back down to help prevent any further bleeding. After Pitocin is going to always be the first one that we want to give, our oxytocin. Then the second line agents are going to be the following. Oh, sorry, I had more. Pitocin, so essentially what it does is it increases the uterine myometrium receptors. So the myometrium is actually the muscular fibers on the uterus. So what it does is it really helps it contract that bleeding. So I said it contracts the uterine smooth muscle, mimicking contractions of labor and transient impending uterine blood flow. So the woman might actually have increased pain, complaining of like similar like labor contractions. We want her to feel that though, because it means the uterus is clamping back down.
Right, because that's what we use when we induce, right? Same medication.
Mm-hmm. Yeah, and then here's the dosages again. So IM would be 10 units, and IV you'll usually give 30 units in 500 or 1,000, and you can bolus. If the mom's postpartum, you can bolus it. If the mom is bleeding antepartum, she's still pregnant, don't bolus. We don't want to bolus our Pitocin. So it's only for essentially a patient who's postpartum. Another drug that we give is Methrogen, and essentially what Methrogen does is it directly acts in the smooth muscle, again, of the uterus, increases the rate, tone, and amplitude of those rhythmic postpartum contractions, helping it contract back down. So the dose is 0.2 milligrams, and it's given IM. The only thing that we want to use caution with is in our patients with hypertension, because it can increase the patient's blood pressure as well. Now, something I want to say about the use of Methrogen and other medication that we're going to talk about is that it does, it could exacerbate their hypertension, but if you're at the end of the road and you have no other interventions, it's rare that it happens, but it could happen. So say you're at the end of the line and you're really struggling for interventions, you actually can give Methrogen to a patient with hypertension. We just want to be more cautious with those patients. Then this is Hemabate. This actually stimulates, again, myometrial contractions to stimulate those contractions as well. It's another IM injections where you'll give 250 mics. And then again, same thing, do not give to a patient with asthma because it can exacerbate, can cause additional bronchospasms. Again, very rare. So if you're running out of interventions and the patient has asthma, you can still give it. It is still safe in patients who maybe just use a rescue inhaler every now and then. And then a side effect to be aware about is that Hemabate does cause excessive diarrhea, and it does happen rather quickly. So unfortunately, in a patient who's postpartum, I would prepare to see the diarrhea occur sooner than later in someone who has received Hemabate. Another medication that we can give is Cytotec. And what this is essentially used for cervical ripening. So we do use it for induction as well. So we use it on labor and delivery to help stimulate labor. Then also it does help prevent postpartum hemorrhage. Now, Cytotec is actually in a pill form.
Very tiny.
Yeah, it's really small. I have some pictures of it up here. And you can actually give it PO, you can actually put it sublingual. You can do 800 or 1,000 milligrams rectally. Now, the reason is we don't want to give it vaginally if the woman is postpartum, because if she's bleeding, the blood and everything is just going to push it out. So rectally actually seems to work best because it's your closest location to your uterus and your vagina where it'll just dissolve. Let's see. All right. And then this is a newer medication that actually just coming out that a lot of OB units are still getting comfortable using. And this is something called tranexamic acid. So TXA is what we call it. Essentially, it slows blood clots from breaking down in the presence of coagulation abnormalities. It's not a uterotonic. It's more of a fibrinolytic therapy. Essentially, the dose is 1 gram and 10 ml, so 100 milligrams per ml at a rate of 1 ml per minute. You want to give it over a total of 10 minutes. So it's a slow IV injection or diluted within a small. You can give it IV piggyback as well if you don't have time to push it slow. It needs to be given within 3 hours of birth, so it's a very quick time frame that needs to be given, and then it can be repeated only once, and that's at 30 minutes. And then just to use caution in your renally impaired patients or in your failure patients. Any questions or comments on that stuff?
TXA's been used for years in cardiac and ortho surgery, so it's really well known to those service lines. It works really well. It's new to us in our service line. You don't see it used as much. Was at a previous hospital where we used it a lot. In fact, there's a lot of studies right now that show that for those patients that are at high risk, that they can get it in a pill form the week before delivery and that it helps. The big caution, of course, is you have to use it within 3 hours of birth. So it's almost like your TPAs. If you had a patient come in, you'd have to know when she delivered, and it's a little tricky that way because otherwise it can cause bleeding.
And then, sorry, the renal thing is like obviously excreted through the kidney. So if they do have that problem with that, they could have a higher chance of toxicity. So we just have to pay a little bit closer attention to our renal patients. Whoops. And then thinking about reporting our systems, learning for every unit is that we need to make sure that we're establishing a culture of huddles for high-risk patients and post-event debriefing. So I'm hoping that you guys have something in place that if you do have a hemorrhage, you can have a meeting about it just to talk what went well, where's areas for improvement. Reviewing all hemorrhages for systems issues. We do this very frequently on OB at a variety of hospitals just to identify what can we do better to make sure that maybe what one of our patients experienced, no one else has to experience. We'll monitor outcomes and process metrics in perinatal QI committee, and then discuss with patients and family members what went on. Now, in these debriefings and meetings with families, et cetera, it's not to point fingers at anyone. Essentially, we want to try and figure out how can we improve our care? What did we do well? What did we do? Where could we improve? And that's part of why this whole initiative happened. Of why now does ED need hemorrhage education? Why, et cetera. So why does this have to happen every year now? And this is kind of stemming from what we're learning is that we need to provide more education to anyone who could be caring for a pregnant patient or postpartum patient. So this is an example of an obstetric team debriefing form. This is actually on the postpartum unit at the University of Chicago. I'm sure you guys have a similar type of debriefing form, maybe not specific to obstetrics, obviously, but I think this is something great to talk about, thinking about how maybe an obstetrical emergency, how it went, what happened, et cetera, and just kind of walking through that whole situation. So what can we do better? And our patients deserve better. And we're trying every day, right, to improve our care and improve our patient outcomes. So essentially the very first thing is preparation is key. And that's part of the reason of why you guys are here. So trying to identify, doing that mental rehearsal that we talked about. So identifying what resources do you have? What's in your ED? Do you have a hemorrhage cart? Do you have these medications? Then what resources maybe need to be developed? Maybe do you feel like you need a hemorrhage kit in your ED? Do you feel like you need more access to medications, or maybe quicker access to talking to an obstetrician if you had someone come in pregnant and bleeding? And do all team members know how or what they are and how to deploy or utilize these resources? So in asking those things of how do I do this? Maybe how do I find this medication? How do I initiate the massive transfusion protocol for an OB patient? So thinking about how can we prep for something like this, and then when it happens, we feel like we can manage it better. Then early recognition of triggers, so empowering the team members, making sure that we talked about some recognition of maybe women who could be at risk, and then making sure that we feel empowered that we can speak up on behalf of our patients if we're feeling uncomfortable with the amount of bleeding maybe we're seeing in a pregnant woman or recently postpartum. We'd rather have you speak up than something actually being happening with the patient and the patient's just sitting there. So really feeling like you can say something and identify what's going on with the patient. Then sequel utilization of patient monitoring, evaluation, medications, and procedures, making sure that we're being aggressive earlier and including transfusion when bleeding continues. We don't want to have a large amount of bleeding and then we have all these resources and then we were just kind of being a little lackadaisical, when really if we would have been aggressive at the beginning, maybe we could improve our patient outcomes. So trying to address them a little bit sooner. And then making sure we have multidisciplinary teamwork, which is what we're doing right now. OB working with ED. So ensuring that you guys are good to work with us and have an easy way to let us know for, say, if a woman's coming in by ambulance or something happened in the ED and you need us, how can you contact us? And then are we ready to come to you? So OB does have emergency kits available on our floor. So if the ED called, how could we get to the ED, our team, NICU, et cetera, to come meet whatever needs you guys might have related to a pregnant or postpartum patient who could be bleeding. That essentially concludes everything that I had or specifically wanted to talk about. And then I guess I'll open it up to questions from any of you guys.
You can either unmute or put them in the chat box or not.
Well, I'll start then. A couple of things. One was oxytocin. We do have, maybe it's more of a comment, we do have oxytocin in the hemorrhage kits, the virtual kits in the Omnicells. So we do have that in both EDs. So that's available. And then the other piece that you mentioned about when a patient is hemorrhaging, how do we notify for, in the OB areas, you guys have the nurse call buttons on the wall. We don't have that in coma. We do have that in the CCD ED, but it really is just stepping out of the room and telling somebody that the patient is hemorrhaging. We need your help right now, kind of thing.
Yeah, that's good.
Yeah. So you guys have the hemorrhage kits on the unit, you said then, Gabe?
Yes, there's a hemorrhage kit, and then there's a there's a hemorrhage, and then a postpartum kit. I think.
Okay.
There's two different ones.
Okay.
They're both virtual.
Okay. Perfect. All right. Let me see. Okay. So Stephanie put in the chat box, when OB comes to Dr. Storks, do they bring a scale for QBL measurement? I don't.
No, not usually. They don't. They bring the supplies for the delivery, but there is a scale on all of our hemorrhage carts. So no matter where the patient would hemorrhage, which of course is usually on one of our units, the scale goes, because everything they're going to need, as she said, besides the medications is in there. Even there's a drawer that's specifically for anesthesia requirements. There's fluids and lines, and we do a lot of packing with a Bakri balloon or uterine packing. That's all stored in there also. And on top is the scale and IV kits. There's even in the Anti-1 some debriefing forms. It's pretty much like a one-stop shopping cart for everything except your medications. So the short version would be no, when they come to Dr. Storks, they don't bring the hemorrhage cart, but it's just as quick to get somebody to bring the hemorrhage cart if it was a situation where the patient can't move up to the, up to labor and delivery.
Yeah, and if that happens too, like I'll just add, like I said, I know it seems kind of gross, but just like keep all your chucks and stuff, like just put it in one spot until you can get a scale. And I mean, sometimes the scales that we use are just like baby scales that we would normally weigh a baby on. So it's not like some sophisticated device. So
yeah, and in fact, that's usually how it is. You just start a pile in the corner of the room and get back to it later because it's all hands on deck. Sometimes these patients go directly to OR. I don't know if we've had that situation. I'm sure in the past we have from the ED, but when all else fails, we will remove the uterus to save the patient's life. So we will take them to the OR, either our OR. We prefer not to, but to do that in our ORs in labor and delivery, but we will if we have to, because that is a longer case, but otherwise, and it ties up our ORs, but we'll like them to go to main OR and do like a manual exploration, give them some anesthesia and actually do a full exploration. And if they can't stop the bleeding, then it's time for a hysterectomy. There is also, they can go to IR. I haven't been here that long to know that they do that. They do that, but I haven't seen it done in the last few months. But if it's a younger patient and they're really concerned about saving the uterus or her bleeding is not as bad, they will do a uterine artery embolization. And stop the bleeding that way. It's quite successful, but it's not all patients are a prime candidate for that. So it's a little bit more tricky. You can't just have a patient come in the door, say that didn't deliver with us or is unknown to us, because you really have to know the patient's history, medical background, and everything that goes along with that. So for you guys on the front lines, it's more getting the IVs going, getting the meds going, and then by then you should have full support from the obstetrical team.
I can't tell you guys how
Good
much
question.
we appreciate you coming down when we have the Dr. Storks. It was pretty scary though when we first opened. We didn't even have Pitocin when we first opened. So
That is kind of scary.
much better now.
Yeah, it's kind of a funny drug, you know. This is how we put people into labor, but it's also at the end when they're not pregnant, sometimes how we save their lives by just bolusing it in. And it is actually a synthetic of a natural hormone, so it's kind of amazing. Yeah. Babies decide to deliver wherever, just like people will hemorrhage wherever. Right?
Mm.
Lucky you.
Any other questions?
No.
All right. Just some housekeeping stuff then really quick. So that leads me, if you guys have any questions, you can find my email in the UFC stuff. But if you don't mind, in the chat box right now, if you can all see it, I actually just put a Google Docs. If you can please sign in, because that's how we're taking attendance. So if you can please just click on that URL, it'll just ask for your name and then your work email. I prefer to use your work email, please. Fill that out, and then within the next 24, 48 hours, you'll get an email from me. It'll contain your post-test. It'll contain 2 links, first one to your post-test, and then the second one to your evaluation. Once you complete both things, then you will get your CE from me within 24 hours of that being completed. Okay. Any questions at all on post-test and eval?
No.
Nope.
Why don't you guys, if you can, go ahead and click on that now and then just log in or sign into that, so that way you won't forget, and then we won't forget to send you the information. So if you can, just go ahead and click on that, fill out the Google Doc, and then you can come right back to the screen.
Gabe, did you happen to write down who was here or no?
I can do some screenshots just in case.
Yeah, just in case.
That one's been signed in.
All right. Cool. Well, once you guys sign in there, you guys are free. I will free you, I guess. But thank you for listening and joining us tonight to talk about OB hemorrhage. Hope you took a lot away.
Great presentation.
Thank you. Have a good night.
Thanks. Thanks for having us.
All right, thanks.
Autumn, I will email you right now the screenshot of who was here.
Okay, I just don't want to miss someone. Like maybe they didn't get the link, or I don't know.
Yeah, no problem.
Okay. Oh, and it looks, I think Starla came on, but I think it was kind of last minute. So, all right. Yeah, if you can just send me that, and then, sorry, that was kind of sketchy. Hopefully my next one will be better.
Okay. Maybe just maybe for the next one, we'll at the beginning tell them to log in.
Yeah.
And then get started with the session.
Okay. Yeah, I'll write down login info so that I can remember. So, okay, perfect. We will see you again in like a half hour.